Thank you for your timely arrival. We're going to resume with the testimony in this case. Mr. Walgren, Ms. Brazil, good morning. You may call your next witness.
Thank you, Your Honor.
You're welcome.
The people would call Dr. Alon Steinberg.
Please raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
You may be seated.
Thank you.
Please state your name for the record. Spell your first and last names.
My name is Alon Steinberg. A-L-O-N is my first name. My last name is S-T-E-I-N-B-E-R-G.
Dr. Steinberg, good morning.
Good morning.
Let me provide you with some instructions, which I give to every witness in every case. The first is to please sit back and relax. The second is to speak loudly so everybody can hear you. The third, if you're called upon to provide a yes or no answer, please use those terms rather than slang which can be a little tricky. And the last is to wait until you hear an entire question before you even start to answer it. In our daily lives, many of us are used to speaking over each other because we think we know what the question calls for. But in a court, we need to wait and hear the whole question before there's an answer. Is all of that okay?
Yes, sir.
Thank you. Direct examination by the people. Mr. Walgren.
Thank you, Your Honor.
Thank you.
Good morning, Doctor.
Good morning.
Sir, Doctor, in what field do you practice medicine?
I'm a cardiologist.
And can you tell us what is a cardiologist?
A cardiologist is a doctor of the heart. After we graduate from college, we go to 4 years of medical school. We do 3 years of internal medicine residency, and then 3 years in what's called a cardiovascular fellowship. Cardio means heart, vascular means blood vessels. The number one disease we treat is really arteriosclerosis or plaque. Why? It's the number one killer in the U.S. of men and women. Why is that? Plaque can rupture, close an artery of the heart, cause an obstruction and a heart attack and death. So we work hard to work on prevention, diagnosis, and treatment. The heart has a structure, and we diagnose structural problems of the heart. The muscle of the heart, if it's weak or stiff, can cause congestive heart failure. There's valves in the heart. We diagnose if it's stiff or leaky. Oh, absolutely. Sure. The valves can be stiff or leaky. The heart is an electrical organ. It needs electricity in order to contract. So if we diagnose problems called arrhythmias, which just means any rhythm that's just not normal, we do a lot of diagnostic testing. We're good at reading EKGs. We do monitors. We do ultrasounds of the heart called echocardiograms. We do various types of stress tests. One of them is called a nuclear stress test, where we can see the flow going into the heart. We do CAT scans and MRIs of the heart. We do angiograms of the heart, where we actually put a catheter into people's hearts and look into arteries. Some cardiologists put stents in to open up people's arteries. Some cardiologists do pacemakers, ablations, which is a treatment to get rid of arrhythmias. Some cardiologists put defibrillators in, which are special pacemakers that can shock and resynchronize the heart. So we do a lot of different tests. We are not cardiothoracic surgeons. Those are doctors that actually surgeons that open up the chest and do bypass surgery and put new arteries and veins or replace or repair your valves.
Thank you, Doctor. And everything you've described then is focused on treatment, care, and maintenance of the heart.
Yes, sir. That's our
As a cardiologist, you're not an expert in sleep medicine?
Not at all.
As a cardiologist, you're not an expert in addiction medicine?
No.
As a cardiologist, you're not an expert in anesthesia or pharmacology?
No.
How long have you been a practicing cardiologist, Dr.
I've been practicing for 13 years.
And can you tell us a little bit about your educational background? Again, you've told us in general terms, the schooling required of a cardiologist, but you personally, if you could tell us, please.
I went to University of Texas for undergrad, and I studied a degree. And then I went to University of Texas in Galveston, Texas for 4 years. And then afterwards, I did my internal medicine residency in Jackson Memorial Hospital at the University of Miami. That's the residency where you work about 80, 100 hours and work at different wards. And then I did my cardiovascular fellowship or my cardiology training at University of Florida in Jacksonville.
And what year did that conclude?
That concluded in 1998.
And what is, Doctor, what does it mean to be board certified?
Board certified means you completed a cardiology fellowship, and then you took an extensive 2-day exam, and you passed it. It's a test that goes over the basic knowledge, skills, judgment calls in cardiology, and it's a good comprehensive exam.
All right. Now, Dr. Steinberg, are you board certified?
I am.
Are you board certified in more than one area of cardiology?
Yes, I have interest in nuclear cardiology, which is the study of radiopharmaceuticals that we mark on the heart, and we can see perfusion or flow into the heart, and we usually combine that with stress testing. I'm board certified in that subspecialty of cardiology, as well as the CAT scans of the heart, which is just a fancy X-ray where we can actually look at the arteries of your heart with a CAT scan. I'm board certified in that.
So nuclear cardiology and the CAT scans?
Yes, sir.
You've reviewed the background and the CV of Dr. Conrad Murray?
Yes, I have.
Okay, and you're aware that he, on June 25th, 2009, he was not board certified?
He was not board certified, yes, sir.
Now, where do you currently work, Dr. Steinberg?
I work in Ventura. Can I make a comment about board certification?
Please.
This one? I just wanted to say that 90% of cardiologists, the first time you take the exam, pass it. That doesn't mean it's an easy test. It means we work hard to test it. But 90% of cardiologists who take the board certification pass it.
Thank you. So your current employment is where?
I currently work in West Ventura County.
And what type of practice or hospital?
I'm in a 9-man private practice group in Ventura and Oxnard, California. We practice comprehensive cardiology. We practice interventional cardiology. We have electrophysiology. Again, we do cardiac CT, MRI, nuclear cardiology, the whole gambit.
And these 9 individuals that make up this practice, are they all cardiologists?
They're all cardiologists, yes, sir.
All board certified?
All board certified.
And do you also have certain privileges or positions at any hospitals in the area?
I'm currently the chief of the Division of Cardiology at Community Memorial Hospital in Ventura.
And as chief of cardiology, what are your responsibilities? What are your duties?
Well, there's quite a few. The first thing I do is really credentialing and reappointment. What that means is when a doctor applies to be a cardiologist at our hospital, I'm in charge of kind of looking at their credentials, seeing what they've done, seeing if they have the proper training, and what procedures they want to do. So let's say a cardiologist applies to put in stents. I make sure he was credentialed before or has the training, and I assign him a proctor or a supervisor to look over him, meaning in the first 5 or 6 procedures, there's going to be a cardiologist in the room with that doctor to make sure that he is competent. And then once he signs off of this doctor, the doctor will gain full privileges. Then every 2 years, we reappoint every doctor and recredential him just to make sure that everyone is practicing competent cardiology and within the standard of care. The other thing we do is quality, meaning we look at quality measures in the hospital. Did everyone with a heart attack get an aspirin? If you come in with a specific type of heart attack called a STEMI, which is a very acute heart attack, did we open up your artery of your heart within 90 minutes? If you have congestive heart failure, did we check how strong your heart is and did you get appropriate medicines? We look at these measures and try and improve them. The third thing we do is something called peer review. peers are doctors of the same level, and we review each other's cases. Why do we do that? To make sure, again, that we're all competent and practicing within the standard of care. But also when we review each other's cases, we improve education, competency, and also we promote patient safety.
Thank you, Doctor. Dr. Steinberg, what is the California Medical Board?
The California Medical Board is a government agency that oversees doctors. They license us, they regulate us, and they discipline us.
And have you volunteered your services, or have you worked as an expert reviewer for the California Medical Board?
Yes, I do.
And what is an expert reviewer in regard to the California Medical Board?
When there is a dispute or concern about a physician, a cardiologist in my case, they ask for an independent review from an expert reviewer. So they ask me to review the case and tell them whether the doctor was within the standard of care.
And when you say the standard of care, what is that?
Yeah. The standard of care is a complicated definition. It's rules, actions, conditions that direct patient care and have been established by authority, custom, or general acceptance in a community, and is reflective of a skilled, diligent physician. You guys don't have to remember that. The most important thing you have to know about standard care is just what your ordinary doctor should do in the same situation.
And is there a kind of a review process or kind of a protocol through the California Medical Board as far as how you conduct the review and what type of conclusions to draw, either with no deviation or...
Right. There's basically three. One is no deviation, that the doctor was within the standard of care and he did fine. The second one is a simple, which is just a minor deviation or difference. And then the third one is extreme deviation, which is a severe or major deviation. That's more or less defined as someone who, it's something from a doctor with good skills should never do, and it could be borderline on unethical. And it's just like ordering a basic test or not recognizing a basic symptom.
And extreme deviation as...
extreme, yeah.
Yes, extreme deviation as used in these reviews and as used by the California Medical Board, is it also defined as gross negligence?
Yes.
Now, did you conduct an expert review through the California Medical Board in regard to this case and the death of Michael Jackson?
Yes, I did.
And prior to this case involving the death of Michael Jackson, had you conducted any other expert reviews regarding any other cardiologists?
Yes, sir.
Approximately how many?
I would say approximately 8.
And in those approximately 8 prior reviews, were there reviews that you conducted where you found no deviation whatsoever?
Yes.
About
I
how
would say
many?
about half. It's half, and then the other half is simple. This was the first time I ever had an extreme deviation.
In this case, regarding Michael Jackson?
Regarding Dr. Conrad Murray.
That's the first time you found an extreme deviation?
Yes, sir.
If we could make sure we're not speaking over each other, it'll help out all of us. Thank you.
I'm sorry, can I have some water?
Happy to. Would you want to wait till we give you the water, or are you able to resume?
No, I can resume. I just
We'll do that.
didn't
Thank you.
realize I should have realized I was going to talk this much.
Now, as a cardiologist, in the practice of cardiology, are there instances where sedatives are used for various procedures?
Yes, cardiologists, we use sedatives all the time because we do procedures, and we want you to be comfortable during the procedure, so we give you medications to relax.
Okay.
And so you can be relaxed during the procedure and cooperative.
And are there instances in cardiology where Propofol is used?
Yes, there is. When most of our procedures that we do, let's say angiograms, pacemakers, I do a procedure called a transesophageal echocardiogram where you swallow a probe into your stomach so we can look at your heart.
I'm sorry, doctor, can you say that term again and maybe
Slowly?
spell it for the court reporter?
Oh my God, I don't know. Okay. It's called TEE, just all capitals.
And it's a transesophageal.
Transesophageal echocardiogram.
Okay, and what is that?
It's an exam where we actually put an ultrasound probe, like the gastroenterologist put an endoscopy into the stomach. We put in a probe with an ultrasound right at the end, right in your esophagus, because when we do an ultrasound of your heart through your chest, sometimes we can't see well through the tissues of your chest. So the esophagus and the stomach are right next to the heart, and we can get beautiful pictures with an ultrasound right in your stomach. So obviously we want you to, when I put something in down your throat, you want to be relaxed and sedated. So we give you medications. Cardiologists, in general, during our procedures, we are experts at mild or moderate sedation. Mild sedation is just taking a little bit of the edge off. You're still awake and talking. Moderate sedation, or I'm sure you've gotten lectures already about this, is nicknamed conscious sedation or named conscious sedation, is a decrease of consciousness, but you're still able to respond to verbal, meaning talking, or tactile, touching stimuli. This is the level of sedation that cardiologists use in general in their procedures and what we're trained in. And actually, when I do, as a division of cardiology chief, one of our privileges is moderate sedation, meaning when you get a privilege at our hospital, you have to show that you've had training in moderate sedation, and you have to pass a written exam, and you have to be proctored or supervised in moderate sedation. And that's just, again, this is not deep sedation. Now, deep sedation is the next in the continuum, meaning the transition of sedation. And deep sedation is you're not responsive, you're only responsive to painful or repeated stimulus. And when you're in deep sedation, there's a chance that you can stop breathing because we're giving a lot more sedation. So most of our procedures are mild or moderate sedation, but one procedure in general that we always do that requires deep sedation is an electrical cardioversion. That's a procedure where you have an arrhythmia, usually what we call an atrial arrhythmia, or it could be a ventricular arrhythmia, but an arrhythmia, and we shock your heart back to normal. When we shock your heart, that can be real painful, so we want you to be sedated to a deep fashion. So when that happens and we need to do an electrical cardioversion, we ask one of our colleagues from anesthesia to come over and put the patient to sleep with Propofol so you're comfortable during an electrical cardioversion. That's the only time I ever see us using Propofol.
One moment, please. Deputy Jones is going to hand
thanks.
Dr. Steinberg a cup of water.
Thanks, man.
Thank you, sir.
So then in your practice of cardiology, with mild or moderate sedation, that's the norm for cardiologists.
That's the norm for cardiology, yes, sir.
And in those settings where you're mild or moderate sedation, what type of sedatives are being used?
We usually use benzodiazepines.
And in your practice as a cardiologist, then, the only time Propofol is used is, for example, in an electrical cardioversion, and when it's used, you would have an actual anesthesiologist administering it and present for the procedure.
We're required in both hospitals I practice in to have an anesthesiologist.
And you alluded to it, but I think you mentioned the word continuum. Is that kind of a scale of going from essentially light sedation to deep sedation at the other end?
Yeah, the continuum, as I said, is mild and then moderate and then the deep that I spoke about, and then the fourth one is general anesthesia, where you do not want to be in general anesthesia. You don't want to be in any pain, so it's no pain. So that usually your airway is compromised and people are on a respirator. That's general anesthesia. So it goes mild, moderate, deep, general anesthesia.
Thank you, doctor. Now, in this case, then, you indicated you did conduct a review of the actions of Dr. Conrad Murray, the defendant in this case.
Yes, I have.
And you reviewed a number of materials as it relates to Dr. Murray's acts or failures to act on the date in question?
Yes, sir.
All right. Now, in your review, is it true that you actually focused your review simply on Dr. Murray's own words? In other words, his description of events from the transcript that was provided to you?
Yes. They gave me a lot of material to review, but I decided on my review I wanted to judge Dr. Murray on his very own words. So I relied solely on his testimony when I wrote out my report.
And in reviewing Dr. Murray's own words from the LAPD interview that the jury's heard, you in fact found 6 separate and distinct extreme deviations from the standard of care.
Yes.
With each one amounting to gross negligence.
Yes, sir. You want me to name them, sir? Or?
I think we'll go through them one by one.
Okay.
And you've listed all of these in your report?
Yes, sir.
Now, the first extreme departure or evidence of gross negligence you noted was that Propofol was not medically indicated. Is that right?
Yes, sir. He was using Propofol for the use of sleep. Propofol is, again, a very strong anesthetic medication, and we use it to facilitate, to make you comfortable during a diagnostic procedure. We don't use it for rest or for sleep or psychological reasons.
And on that issue of sleep and sleep care, did you note in your report certain requirements, aside from the Propofol is not medically indicated, but just some basic tenets of sleep care?
Repeat the question, sir.
You indicated in your report that there requires discussion with the patient.
Oh, yeah. Before you give anyone before you do a procedure or give sedation, you need to get something called informed consent. When I do a procedure on you, which includes sedation, I discuss the risks, the benefits, the indications, and the alternatives of the procedure. Like that test I was talking to you about, the transesophageal echocardiogram, that the number one risk of that procedure is rather benign. The number one risk is really the sedation, because there's a risk of you stopping to breathe. So I always explain that and explain the risks and benefits.
And that issue of informed consent, written informed consent, that's a basic tenet of competent medicine, isn't it?
Yes, sir.
Where as you said, the risks and the benefits of the procedure are properly explained to the patient prior to going into the anesthetic or the procedure.
Yeah, and we want you to understand what's going to happen. And unfortunately, anytime we do a procedure or give sedation, there are risks, because when we give sedation, it can stop your breathing. You can obstruct your airway, meaning you can lose control of your throat muscles, and your tongue can move back and obstruct your airway. And also, you lose control of what goes into your stomach. I mean, what comes up from your stomach. It could go into your airway and go into your lungs and cause a dangerous pneumonia called an aspiration pneumonia. So when I do a procedure on you, I want to understand, God forbid something like that happens, I wanted to explain that was a risk to you.
And prior to your involvement in this case, and your analysis in this case, had you ever heard of any doctor using Propofol in their practice of medicine to treat insomnia?
I've never heard of it.
And in your opinion, is the use of Propofol as part of a doctor's medical practice to treat insomnia gross negligence?
Yes. It's indicated for procedures and patient comfort, not for sleep. That's extreme deviation from the standard of care.
And the second deviation you found was what?
A second deviation is that putting propofol, giving someone propofol in someone's home, unmonitored, without the proper equipment, medical personnel or backup, was also an extreme deviation from the standard of care.
Okay, and you've actually listed numerous things under that heading. So in the home setting without the proper equipment.
Yes, sir.
Without the proper personnel or staffing.
Yes, sir.
And without the actual physical observations of the attending physician.
Yes.
So let's go through these. And would each of these individually, although you list them as one extreme deviation,
yeah.
Isn't it true that each of these individually would in fact be individual accounts of gross negligence?
I agree.
So let's talk about the lack of equipment.
Yes, sir.
Let's talk about that. What, in this type of setting, let's say in a hospital or an outpatient clinic or wherever the propofol may be being used, what is the standard of care as far as monitoring equipment that is required?
Okay. There's quite a few things we're going to go over.
This is a little bit vague. There's no clarification as to the type of sedation.
All right, I'll sustain the objection. Refine the question, please.
In regard to the standard of care, as to the use of propofol, okay, when propofol is administered to an individual, what is the standard of care as to the appropriate monitoring equipment that is required?
Okay. The standard of care for someone who's getting propofol should be monitored. There's a lot of things that you need to have monitored and a lot of different types of equipment. First, you need a pulse oximeter with an alarm, meaning a pulse oximeter. I think you guys got a lecture on that, right? A pulse
we're not going to have a dialogue with the jurors.
Okay.
So just
Sorry.
please answer. That's okay. Please answer the question.
A pulse oximeter with an alarm.
Pulse oximeter with an alarm, and you want to check it checks the oxygenation in the heart. And if it gets to be a low level, meaning the oxygen is low, then that's concerning, and you want to have an alarm saying, "Help! There's a problem." Dr. Murray's machine did not have an alarm, and so if you can imagine, if you have to monitor this person the whole time, you have to be staring right at that machine every second while they're on sedation and on propofol. So that was grossly negligent and extreme deviation of standard of care.
In addition to the pulse oximeter, what is the standard of care type of equipment that is necessary?
Okay, so he did have IV equipment, but he did not have an automated blood pressure cuff. That's a cuff that checks your blood pressure so you don't have to do it yourself. He did have a manual cuff, but it was not in use. You should be checking the blood pressure while getting propofol every 5 minutes at least. And that was not done.
Is there more equipment that is required?
Yes, okay. The next thing you need is an EKG monitor, so we can monitor your heart rhythm to make sure no bad arrhythmias occur. He did not have an EKG monitor.
And how does the EKG monitor work?
You put electrodes on the chest, and then we can see how the heart rhythm is on a screen. So if there was a normal rhythm, you could see it, and if there is extra heartbeat, sometimes that can be an early sign of irritability. And when the patient starts to get low oxygen, the heart starts to be stressed, you can start having arrhythmias. And so you want to have a monitor in order to monitor arrhythmias.
In addition to the blood pressure, the pulse oximeter, and the EKG,
Yes.
what additional equipment?
You need oxygen, and he did have an oxygen. I don't know the exact oxygen supply he had, but you should have various types like nasal cannula through the nose or a mask. You need suction, because as I told you, you can regurgitate things into your mouth. Suction is what you see at the dentist when he sucks out your saliva. You want to have that so in case someone regurgitates, the nurse can quickly go in there and suction out these things from your stomach before it goes into your lungs. The other things you need is a bag mask or an ambo bag, and you need to know how to use it. An ambo bag is a oxygen mask. It's connected with a valve and a large air chamber that looks like a football. And what happens is you can give positive pressure oxygen, meaning you put the mask on and you can push oxygen into someone's lungs. Dr. Murray had an ambo bag, but he did not use it.
And you're taking that from his own statements where he states that he did mouth-to-mouth on the patient but makes no mention of using the ambu bag.
Yes, he gave mouth-to-mouth, and he did not use the ambo bag, but on a picture I saw that there was an ambo bag on the floor.
Okay.
The next thing, which is probably the most important, is a way to summon for help. When we give sedation or do a procedure, we either have a nurse that we can have call the rapid response team or the code team, or we have a button that we just press and the cavalry comes over to help us.
What do you mean by the cavalry?
Well, usually it's multiple nurses, a respiratory technician, sometimes an anesthesiologist, or a emergency room doctor who's adept at fixing someone's airway and intubating the patient.
And any other required equipment for this area that you're talking about, the monitoring?
Yeah. Well, one documentation we'll talk a little bit later. You need a good room with nice lighting. You need a backboard. Everyone has a backboard. That is a hard surface board that we can put underneath the patient. God forbid the patient has an arrest and we need to give CPR. The patient's usually on a soft bed. And when we give CPR, we have to push down with our two hands 2 inches down their chest. And if we do it on a soft bed, we're just going to displace the patient down 2 inches. So we put a backboard underneath them in order prior to doing CPR. The other things you need is a backup battery. In Ventura County, we had a blackout about a month ago. I know there was one in San Diego. God forbid you're sedating someone and the lights go out, you should have a backup generator.
And that would be for the various equipment you've described?
Absolutely, the pulse oximeter, the automated blood pressure cuff, because if the lights go out and your patient becomes hypoxic, you may not know what's going on. God forbid they have an arrhythmia, you don't have an EKG monitor, you can't defibrillate them because the defibrillator will not be on. The other things you need,
Yeah,
the other things you need is an oral pharyngeal airway. I've told you how sometimes the tongue can slip back and obstruct the airway. It's a little device that keeps the airway open. And then very important, it's utmost importance, you need equipment to rescue the airway, like a tube to put down people's throat into their trachea and lungs, just in case someone stops breathing and you use the bag mask and it doesn't help. We need to be ready to intubate the patient. So you need to have that nearby.
And that's an endotracheal tube?
Endotracheal tube, yes, sir.
And that would also, when you're administering Propofol, you would have to have someone trained to also be there to manage the endotracheal tube and get it put into the patient, essentially.
Yes. Yeah. We only use mild or moderate sedation when we're a cardiologist. But sometimes in the procedure, the patient can get over-sedated. They usually don't. Over-sedated, there's equipment that's still in the room, and an anesthesiologist or emergency room doctor with a press of the button can come over within a minute or two and intubate the patient.
And Dr. Steinberg, you indicated they can become over-sedated. Usually not, but they can. That's a foreseeable, likely consequence.
Absolutely.
And that's this continuum where a patient can actually cross from, for example, light sedation or into moderate sedation, and you can pass from moderate sedation into deep sedation. And that's one of the dangers and risks that you need to be prepared for, correct?
Yes, sir. And absolutely. With Propofol, I understand it has a very narrow therapeutic threshold, meaning you can go from one edge to other quickly.
In addition, then, you mentioned the airway management equipment and the endotracheal tube. Any other equipment?
As I said before, there's a defibrillator. That's a special machine that we shock people's heart back to normal. There should be a defibrillator, and it should be on, ready to use. The other thing is you need a lot of special drugs when we're giving sedation. He had one of them called flumazenil, which is a reversal agent for benzodiazepines. That means it's an antidote to benzos. Those are one of the required ones. The other ones are Narcan that reverses narcotics. If someone has an arrhythmia, we should have amiodarone, lidocaine, beta blockers that can stabilize the rhythm. If the heart rhythm is too slow, we should have atropine to increase the heart rate. If the blood pressure is too low, we should have medications like dopamine and epinephrine in order to increase the blood pressure. If there's an allergic reaction, we should have prednisone. If the sugar is low, we should have dextrose.
Anything else as far as the typical required standard of care equipment?
Very important, when you're giving sedation, you should have an assistant to help you who's ACLS and BLS certified, meaning that when you're giving sedation, things can happen. You can't always monitor somebody, and there may be a lot of things to do. You should have someone there who's trained to know what to do.
Let me ask you before you said ACLS and BLS certified.
Yes.
What is BLS?
Sorry. BLS is basic life support. That's the basic course you guys take for cardiopulmonary resuscitation, CPR. You learn mouth-to-mouth skills, how to do chest compressions. ACLS is more advanced life support, or advanced cardiac life support. Those are things we usually do in the hospital. They deal with, putting an airway in somebody, IVs, different heart rhythms, different conditions that can happen, different arrests, different medications we give. It's a little bit more advanced.
And that person, someone trained in both BLS and ACLS, is part of the staffing requirements to safely administer Propofol.
Yes.
And again, in one heading, you talked about the equipment as well as the staffing. But again, both of these would be independent, individual extreme deviations?
Yes.
Now, you went on to describe a third extreme departure or third finding of gross negligence, and that was inadequate preparation for complications or emergency.
Yes, sir.
Can you describe your findings in that regard?
Yes, sir. It goes a little bit with the equipment and monitoring. When you have all this equipment, you need to be prepared to use it. You need to be prepared to call for an emergency. You need to be prepared to have the flumazenil ready to inject it in case of a problem. You need to know how to use. There was a bag mask there, an ambivag. You need to be prepared to use it. If someone's not breathing, you need to be prepared to intubate somebody. If you have a low blood pressure, you actually have to have a monitor and the medications potentially ready to give it to them. And if in case of emergency, you should have a person there ready to call for help or assist you. Those are examples of things that he was not prepared to do.
And the next finding of extreme or gross negligence you noted was improper care during the arrest.
Yes, sir.
First, what do you mean by during the arrest?
An arrest is when something stops. In Mr. Jackson's case, it was his breathing. So when he was trying to resuscitate and help Mr. Jackson, he didn't follow appropriate protocol.
And can you describe, again, as a cardiologist, when there is an arrest situation and there is respiratory depression, that will then lead to cardiovascular depression or failure?
It can. Can I explain an arrest a little bit?
Please.
Okay. I'm going to explain very briefly.
Your Honor, there's no question.
The objection sustained.
Would you
A
please,
question and then an answer.
would you please explain what an arrest is, Dr. Steinberg?
Yes, I'm going to explain briefly a cardiac arrest and then Mr. Jackson's respiratory arrest. A cardiac arrest is what you normally know as a heart arrest, is that the heart stops beating. Essentially, you go into an arrhythmia, likely due to a structural problem or a heart attack. The heart just goes into an arrhythmia called ventricular fibrillation, and it doesn't contract. When it doesn't contract, there's no blood pressure and no blood moved. So the patient collapses, or you find the patient down. When you see that, that's most likely a cardiac arrest. So the most important thing is to get a defibrillator because you want to shock that person back. So when you see that, you got to call 911 and tell someone to get a defibrillator, and then you go down and start doing chest compressions or CPR. When we do CPR, we're trained to have someone on a flat surface, and we use two hands, and we go down 2 inches. What happens is this is the heart, and when we press down, we increase the pressure in the lungs and push down in the heart, and that pushes the blood forward. When we release, the heart fills up with blood, and then we push down, and the heart flows forward. So that keeps the blood circulating, waiting for the defibrillator. That's a cardiac arrest. And a respiratory arrest, like Mr. Jackson had, he stopped breathing. There's still oxygen in the lungs, though. And so the oxygen slowly goes down, but the heart is beating fine. It's normal. But when the oxygen gets lower and lower, the heart realizes it and the brain realizes it, and it starts to get excited. It starts to beat harder and stronger because it needs to circulate the lower density of oxygen in the blood system. This is approximately where Dr. Murray found Mr. Jackson.
And again, you're basing that on Dr. Murray's words?
Yes, because I'll expand. But
We'll have a question, please.
No, so you were indicating then at that time, this is where you were describing how the heart's reacting to the respiratory failure.
yes, sir.
And then, please elaborate. You stated that this is where Dr. Murray found Mr. Jackson?
Yes, but I want to. What happens if you don't do nothing is, and what happened also with Mr.
If you do nothing?
Let's say, and naturally, let's say there's no one there. What slowly happens is the heart starts to weaken because the heart is muscle and it needs oxygen to work. So when it stops getting oxygen, it just stops working. But the electricity is still going, but the heart's not contracting. That's something called pulseless electrical activity, meaning there's electricity, but there's no contraction and no pulse. The next step after that is the electricity dies and you get asystole. What happened, why I think that's where Dr. Murray found Mr. Jackson. We're going back to the heart. He reported in his report that when he left Mr. Jackson's side, the oxygenation percentage was in the high 90s, which was normal, and the heart rate was 70, which was normal. He stated he left for 2 minutes. And so when he came back, Mr. Jackson wasn't breathing, and the heart rate was 122. But we know there's a blood pressure for 2 reasons. One, he checked a pulse, and they indicated as a pulse, that means there's a blood pressure. A pulse oximeter will not detect a heart rate unless there is a blood pressure. So we know there was a blood pressure. There was no automated blood pressure cuff to tell us that there was one. So when he approached Mr. Jackson at this point, what he should have done was first called 911, run over, try to arouse Mr. Jackson. Sometimes we do a sternal wound that arouses the patient. He should have grabbed the ambu bag, tilted Mr. Jackson's head, make sure he wasn't obstructed, and start using the amvo bag with a positive pressure and trying to get the oxygen up, reaching and finding his flumazenil, and then giving him flumazenil immediately as soon as he can. What he did do also, which I think is inexcusable, he started doing chest compressions. As I told you, there was a blood pressure. When there's a blood pressure, this is a respiratory arrest. This is not a cardiac arrest. So the heart is still contracting. The key is, remember, you want heart to get oxygen because without it, it's going to stop. So instead of just calling 911, instead of immediately giving flumazenil, instead of using the bag mess to get oxygen in him, he started doing chest compressions, which is counterproductive on a heart that's already working. So the fact that he was doing that was an extreme deviation from standard of care. The other thing is that his CPR were poor quality. If you guys feel your chest, it is hard. And in order to get good chest compressions, you got to go 2 inches. Could you imagine doing that with one hand or underneath a soft bed? You can't. So he should have put Mr. Jackson on the floor because he didn't have a backboard and done CPR on the floor with 2 hands.
And you're aware that Mr. Jackson weighed 136 pounds, correct?
Yes, sir.
And how would Dr. Murray, with his size, place Mr. Jackson on the floor to do appropriate compressions?
Gone behind him, lift.
Just a moment, please. Once again,
Sorry.
it's very important for both parties to just wait till the other speaks. Please, a question and an answer.
I know,
Thank
my
you.
fault.
And the court reporter needs to get down everything we're saying, so we have to. So you're aware of Dr. Murray's size, and you're aware that Mr. Jackson weighed 136 pounds. How would Dr. Murray put Michael to the floor?
I would get behind Mr. Jackson and slide him down.
Okay. And you would get behind, I assume, his, Ms. Brazil doesn't mind, his torso area and under the arms, and just protect the head and let the feet drop?
Yes, sir.
And that would be a very easy procedure?
I would think so.
Now, you also commented in your findings regarding, well, let me just ask you, so what you've described during the arrest, according to Dr. Murray's own words, the heart rate that he observed, what he should have done as far as calling 911, arousing Mr. Jackson, using the ambu bag, going immediately to the flumazenil, placing him to the floor, doing appropriate two-handed compressions with a hard surface. All of these actions during the arrest indicated, the failure to do these actions indicated to you gross negligence and an extreme departure?
Yes, sir.
Now, the fifth extreme departure you've identified was a failure to summon emergency help, which you've commented on briefly. Explain that for us, please.
Yeah. It's basic knowledge in America. You don't have to be a healthcare professional. That when someone is down, you need to call 911 for help. Dr. Murray should have known that. When he saw Mr. Jackson down, he should have known, I have none of the equipment to help Mr. Jackson. I have none of the medications. I have no help, any other personnel, medical personnel that can help me. I need to get help quick. And one of the first things you should have done is call 911. There was a significant delay in calling 911. I understand he could have called 911 at the beginning code around noontime, but then there was a significant delay to calling anybody at all. And then when you call 911, instead of calling 911, he called Mr. Amir. Mr. Amir?
Michael Amir Williams.
Michael Amir Williams. Mr. Michael Amir Williams. Instead of calling 911 and saying, I'm at 100 Carrollwood, come fast, I'm a physician, we're giving CPR, come on over, he calls his assistant, and there's a further delay of at least 8 or 9 more minutes.
And let me stop you. And you're aware from, again, Dr. Murray's own words, that he admits that he didn't even ask Mr. Williams to then call 911.
He did not ask Mr. Williams to call 911. And apparently, the paramedics, the EMS, emergency medical service, they were only about 4 minutes away. So instead of that huge 20-minute delay, I didn't even count, 20-something minute delay, he could have gotten help that he needed within 4 minutes.
As a cardiologist, in this type of situation where you have respiratory depression leading to eventually cardiovascular failure, describe the significance of even a 30-second delay or just a 1-minute delay in making that 911 call to get the necessary equipment and assistance to the site.
Yeah, we have statistics. I'm not well versed at it, but for every minute that there's a delay in calling EMS during a code situation, there's a less and less chance that that patient will survive.
Every minute counts.
Every minute counts.
And even if the delay, even if the patient may survive, you could have permanent brain damage by
Absolutely.
delays.
Yeah, yes, sir. If the brain doesn't have oxygen for about 10 minutes, there starts to be permanent damage to the brain.
Now, you said in your report in regard to the failure to immediately call 911, you actually described Dr. Murray's behavior as, quote, bizarre. Can you elaborate on
I
that?
just thought it was strange that a medical professional who needed help should recognize the fact that he needed help, and then when he had an opportunity to call for help, he did not call 911. He called an assistant. When he could, in that short time that he had a conversation or used a call, he could just call 911, put even the phone on speaker, and be able to work at the same time as talking to EMS and help.
And an additional, then, extreme deviation from your report, you note, is the failure to maintain proper medical records. Can you describe that, please?
Yeah. I want to describe why. He asked me why we give medical records, why it's important. There's 3 reasons. One, our insurance, the first 2 are not so important. One, it's the insurance companies who want us to document because they want us to document and justify what we get paid and when we order tests. The second reason is litigation, meaning anytime there's a conflict, let's say with a patient, we have documentation of exactly what we did. But the most important reason why we document is to take better care of you. When you come to see me, I write down your complaints, your history, your allergies, go over your medications. We take your vital signs. I do a physical exam and write it down. I go over your lab work. I go over any diagnostic tests you had done. Then I make an assessment and I make a plan of action. If I do a procedure on you, again, I get informed consent, I discuss the procedure, risks, benefits, and alternatives, and I have you sign that you understood that. And when I do a procedure, we have everything documented what exactly happened. And why is that? So when you come back, first of all, I know what's going on. Because I can say, oh, you know, how is your breathing now? Oh, you know, I'm not going to give you that medication because you had a reaction to it. Your blood pressure was high last time. You know, I didn't hear that on physical exam. Your blood count's down. Your EKG looks different. The other reason is that other people can take better care of you. If you move to San Diego or I send you to a consultant, they have everything. If you come to the emergency room, our emergency room at night, my partner can pull up your medical records and he can know exactly what's going on with you so he can take better care of you. Dr. Murray did not document a single thing. He didn't document, you know, Mr. Jackson, when was the last time you ate? Because he's giving Propofol. And there was no history. There was no vital signs documented. There was no physical exam. There was no informed consent, meaning, Mr. Jackson, do you know I'm giving you this powerful medication, unmonitored? Do you understand the risks and benefits? He didn't have one single vital sign while giving this medication. We always write down what medications we give and their reactions. And when he came to the emergency room, he was confused and didn't have all the information that he could give to the emergency room doctors at UCLA about what exactly he gave.
Now, you're assuming
May
that
I
was...
just have a moment? The mic went out. Deputy Jones needs to reset it. Give us a moment, please. Steinberg, want to just flip the mic, see if it's working? Good enough. Thank you. Sorry.
Dr. Steinberg, you indicated he was confused at UCLA. The other option is he was simply being intentionally deceptive, correct?
It could be. I don't know.
And again, because you're basing your analysis...
I'm basing my analysis...
Let me finish.
We need the question.
Sorry.
You're basing your analysis on the words of Dr. Murray and giving him the benefit of the doubt, interpreting the evidence as he explained it.
Yes.
Whether confused or dishonest, Dr. Murray did not have the medical records to provide to the caregivers at UCLA.
No, it would have been appropriate for him just to hand over the records. This is what Mr. Jackson got at what time. This is his history. This is what he's on. This is what he's allergic to. And then the doctor would have had all the records of what happened.
Now, in reviewing these multiple extreme departures or findings of gross negligence, you concluded in your report that the breaches of the standard of care directly contributed to Michael Jackson's untimely death.
Yes, sir.
And what did you mean by that?
Well, all those deviations, giving Propofol in an unmonitored setting without personnel, without appropriate monitoring, without the appropriate equipment, not being prepared, not doing appropriately reacting to the arrest, not calling 911 on a timely fashion, all directly impacted his life. Because if these deviations would not have happened, Mr. Jackson would have been alive.
And when administering benzodiazepines, as Dr. Murray said in his interview, and let's just assume only 25 milligrams of Propofol, since you're basing your analysis on Dr. Murray's words, in that type of administration in this setting, isn't it absolutely normal and foreseeable risk that you could have respiratory depression and potentially cardiovascular failure?
Yes.
That's a normal, reasonable, foreseeable consequence. That's why all these safety precautions are necessary.
Yes, sir.
And there's nothing unforeseeable or extraordinary or abnormal about that risk of respiratory depression and cardiovascular failure in this situation.
No.
Now, let's assume for the sake of argument that everything happened as Dr. Murray described in his interview, and that apparently because Dr. Murray left the patient alone, Michael Jackson was able to consume some additional agents, maybe lorazepam, maybe additional propofol. Would the standard of care and what you've described that Conrad Murray did, would his actions, Dr. Conrad Murray's actions, still be a direct cause in the untimely death of Michael Jackson?
Yes. I mean, all the standards that were breached that I just stated are still admissible. I mean, he gave Propofol in an unmonitored setting. He gave Propofol with a poor indication. He responded to the arrest inappropriately. He did not have an appropriate response to an emergency. He did not call 911 on time. He did not document. All those things still apply.
And if the patient, Michael Jackson, was able to administer to himself either lorazepam and or propofol without Conrad Murray's knowledge, doesn't that by necessity mean Conrad Murray was neglecting or abandoning the patient for that to happen without Dr. Murray's knowledge?
Yes, sir. I want to, again, I didn't think I said this, but when you monitor a patient, you never leave their side, especially after giving Propofol. It's like leaving a baby that's sleeping on your kitchen countertop. You look at it, and it's probably going to be okay, and you're just going to put some diapers away or go to the bathroom. But you would never do it because there's a small, very, very small chance that the baby could fall over or wake up, get startled, and grab a knife or something. So you always monitor the patient. When we also in the hospital, when we give conscious sedation or any sedation, the drugs are in cabinets. We keep it in something called the Pyxis machine, which is like a vending machine, and we account for all the medications, and we don't give an opportunity for the patient to self-administer.
And that system that you just described, it's actually a locked cabinet, and it's password protected, isn't it?
Yes, sir.
So only a privileged staff member with the authority to go into that cabinet and get and retrieve the medications is permitted to go in there and get these secured medications.
That would be like giving Mr. Jackson a key and a code to his own machine.
Okay. But in the hospital setting, this cabinet is locked and only available to the person that has authority to retrieve the medications.
Yes, sir.
And the reason that is done is because it is foreseeable that someone could voluntarily take the medication inappropriately. They could accidentally take the wrong medication. All that is foreseeable, correct?
Yes, it's all for we treat every patient the same.
Thank you, Doctor. Nothing further, Your Honor.
Walgren, thank you. Cross-examination by the defense. Mr. Flanagan,
Could we take a brief recess?
you want to take the mid-morning break?
Yes, please.
All right. Ladies and gentlemen, let's take the mid-morning break. Of course, please remember all of the admonishments and orders in writing and verbally. We'll take a break until about 10 minutes after 10. See you at 10 minutes after 10. Thank you.